Welcome to Putting the Puzzle Pieces Together, Best Practices in Hospital-at-Home Logistics, a webinar sponsored by the Hospital-at-Home Users Group, presented in partnership with the American Academy of Home Care Medicine and the American Hospital Association. I'd like to recognize the generous support of the John A. Hartford Foundation for the Users Group and this webinar series. The Users Group is the nation's premier collaborative focused on acute care at home. The Users Group shares resources and best practices, works together to expand our program's reach, and informs regulatory, reimbursement, and payment policies necessary to build the field and spread this hopeful, person-centered model of care. Please visit our website. Be sure to check out our TA Center for useful hospital-at-home program resources and tools, as well as our recently refreshed Research Center. You can follow us also on Twitter or X. If you have time and certainly the interest, you can view any of our 29 users group webinars on our website. This is our 30th webinar that we've done since 2021. Please find a topic you've been thinking about or working on and take a look. Finally, a team of researchers at Mount Sinai is looking to interview hospital-at-home caregivers for their input on the caregiver experience and a range of equity issues related to hospital-at-home policy, practice, and research. We need your help to connect with caregivers. So to get involved, please simply scan the QR code on this slide or contact us at info@hahusersgroup.org. It's now my pleasure to introduce our moderator for today's webinar, Dr. Linda DeCherry, a member of the Hospital-at-Home Users Group leadership team and a national expert on hospital-at-home programs. Dr. DeCherry is the Vice President for Clinical Strategy and Implementation at Medically Home, where every day she helps sites around the country implement virtual hospital-home programs. Previously, Dr. DeCherry was at the Mount Sinai Health System for almost 2 decades and was the clinical director of Mount Sinai at Home, its home-based service line. Please take it away, Linda.
Thank you so much. So I am very excited for today's webinar. Gab, if you can go to the next slide. Sometimes this is one of the most challenging parts of hospital at home. It's intake and logistics, sometimes I think, are really some of the biggest challenges. So I'm really excited for our speakers today, who are each going to speak on a variety of topics. So let me explain the layout of how today's webinar is going to go. After introductions, I'm going to have everyone explain a little bit about their program. Then we're going to go into 3 topics. We're going to talk about transportation, DME, and diagnostics, excuse me. And we're going to have 1 speaker for each of those, and the other 2 speakers will comment on how their program might be similar or different on those, and we will have, between each section, time for Q&A. So start thinking of your questions now. I'll repeat the 3 topics: transportation, DME, and diagnostics. All right, so I'm going to go now to introduce our fabulous speakers today. So we're welcoming today Doug Bretzing, who attended Baylor Scott White's internal medicine residency program, where he also served as chief resident. He joined Baylor Scott White Hospitalist team and shortly thereafter became the associate director of inpatient medicine. He is now the medical director of Baylor Scott White's Health's hospital care at home service line, and has been instrumental in designing, launching, and scaling hospital at home within the system. Doug was awarded Clinician of the Year in 2023 by the Hospital at Home Users Group for his accomplishments. Our second speaker is going to be Dr. Peter Chang, who is the Senior Vice President, Chief Transformation Officer at Tampa General Hospital. He's responsible for designing forward-looking healthcare strategies to improve clinical quality, efficiency, and care coordination while decreasing the total cost of care. As part of this mission, Dr. Chang led the design and implementation of Tampa General Hospital's Hospital at Home program. Prior to his role in design, he created and operated Tampa General's clinical command center focused on system-wide efficiency and quality, and served as an assistant professor of medicine in the Department of Hospital Medicine. And last, we have Dr. Hamali Sudhakar, She's an internal medicine hospitalist and palliative care physician at the Permanente Medical Group in San Jose, California. She serves as the Regional Medical Director of Hospital Quality and Care Experience for the 21 medical centers within Kaiser Permanente's Northern California region. She has a Six Sigma black belt in process improvement and actively applies lean methodologies to enhance care delivery. For the past 4 years, she has directed quality and safety for the Advanced Care at Home program in Kaiser Permanente's Northern California and assumed oversight of operations in January 2024. So welcome. No one has any disclosures to report. And I am going to go ahead, next slide. Turn it over to Dr. Bharat Singh to explain a little bit about his program.
Well, thank you, Linda, for the introduction, and thank you to the users group for this opportunity to participate. So Baylor Scott White Health is a fairly large health system with 52 hospitals across Central and North Texas. We are a nonprofit organization. We launched Hospital at Home in February of 2023 as a joint venture, and then we relaunched in June of 2024 as a wholly Baylor Scott White owned and operated service line. We are currently live in 3 of our hospitals. Temple, which has 636 beds. It's a quaternary care center and a teaching institution. And that's Temple's in Central Texas. McKinney is in the Dallas Northeast region with 192 beds. And then College Station, again, a Central Texas hospital with 142 beds. And our current daily census ranges anywhere from 6 to 12 patients.
Now I'm going to turn it over to Dr. Chang.
Thanks, Linda. So Tampa General is a 7-hospital system in West Central Florida in the kind of the crux of the Tampa Bay area. We have a 1,000-bed hospital along with 3 community hospitals up north, and then some ancillary behavioral health and inpatient rehab hospitals. And so I'll focus a little bit more in on our hospital at home kind of journey as we've gone through this since 2022. We're well over 1,000 patients now, total seen. We run an average daily census of around 13 and a half patients, up to 17 and 18, of course, at times. Bed days saved is over 4,000 at this point, which is really an amazing feat, along with our readmission rate and running at about 5.5% compared to about 15% on the inpatient side. We do some of our own patient experience scoring. As we know, our Press Ganey surveys have not kept up to speed with what's going on with hospital at home. And over 155 DRGs treated, and really focusing on some interesting populations. 10% of all of our liver transplant patients have been taken care of in hospital at home. So we'll transfer them at post-op day 4 or 5 and finish the rest of their transplant care at home. And starting to expand to malignant heme, bone marrow transplant, CAR-T, and neutropenic fevers, which is really a new territory for us within the home. We kind of rate our clinical capabilities, and we recently added blood transfusions, which was a huge accomplishment for our hospital home program, and have opened up close to 80% of total payers with the addition of Medicaid being added in Florida. We have not opened up any Medicaid programs quite just yet. It just happened in December. And seen significant growth in our team over the last couple of years as we're really starting to grow this as its own service line. But that's a little bit about TGH at home. Thanks, Linda. I'll pass it back to you.
Great. And now I'm going to have Hamali speak about Kaiser.
Thank you. So we have about 9 regions across the country for Kaiser Permanente, and today I'm going to talk about the Northern California region. We serve about 4.6 million members in Northern California, which includes 21 medical centers across, if you see all the way down south from San Jose, all the way up in Roseville and Santa Rosa. We have about 10,000 physicians, about 40,000 plus nurses and staff, and 100 plus specialty. For advanced care at home, we have, and we don't call it hospital at home, we call it advanced care at home because California does not have the hospital waiver. And so we have created a benefit in the home, under home health licensure with wraparound physician and ancillary services. So hence we call it advanced care at home. We are located in 4 counties currently, which serves 8 medical centers. That includes the medical centers here in the circle, red circle you can see. It takes us a while because we have to file for the benefits. We can do commercial and group Medicare right away, but for individual Medicare, it takes us about a year to apply. And that's how we expand to different regions. You can go to the next slide. We started in late 2020, and as you can see, till about early 2023, we had a very slow growth. We were very small scale pilot. We were very expensive and under-resourced. We also were having this good catches, so we had never had any event, and we had to make a hard decision to pause the program. And we had to go back to our executive sponsors and say, if you want to do it right, we need to actually invest in the infrastructure and growth. And so we came back in full swing in mid of 2023, and we had tripled our census in 2024. Our average length of stay is 4.2 days. ADC is about 22 with a cap of 30. We admit anywhere from 2 to 9 patients daily. 9 is a stretch for us till we get more staffing. And till date, we have about over 2,000 patients, 2018 till last week. And last month was our highest month at 156 admissions, and we're looking at 170 for the month of January.
Great, thank you. And I'm just going to just for level setting, just so it's clear, I believe that Doug and Peter, both of your programs are predominantly waiver programs. Is that correct? Or Doug nodded. I know Hamali is not. So.
Yes, we're mainly waiver programs with the addition of our commercial clients.
Perfect. Okay. I think that just helps because obviously all of that makes a big difference for logistics as we move forward here in this webinar. All right. So we're going to start now with transportation and Doug is going to start us off with that.
Great. Thank you. So of all the topics that fall under the large umbrella of logistics, we chose transportation to be one of them because seamless transportation of your patient from the hospital to home is paramount. In my conversations with medical directors across the country, I've learned that for many programs, transportation is the rate limiting step to patient throughput. Some medical directors have lamented that they have to wait 3 to 4 hours sometimes from the time that they ask for transportation until their patient's leaving the facility. And so, logistics and downstream operations significantly rely on smooth transportation. And then from a more patient-centric perspective, this is one of the first touch points that the patient has while they're on our service. So we've recently, we've just approached a patient in the ED or on the medical floor. We've told them about our program. This might be the first time they've heard anything about hospital at home. They've decided to take that leap of faith and to do their, to trust us with their care. And then after that, our patient may fall on somewhere on a spectrum of, anxiety and nervousness about what they just agreed to. Not sure how things are going to go, wondering if they made the right choice. And so, if transportation from the hospital to their home goes very smoothly, goes seamlessly, that does a lot to building confidence for our patients in our ability to care for them. But the converse is also true, where, if that process does not go smoothly, then we can very quickly lose trust or our patients' trust. One pro tip that I never really thought about until I was discussing, following up with one of my patients on his transition from the hospital to home. And he mentioned it went very smoothly, other than he got motion sick in the back of the EMS truck. And I asked him, is that something that, you have had problems with previously, motion sickness? And he said that it was, but he didn't think to mention it to me, and I didn't think to ask. And that's something I could have very easily pre-treated him for. And so that is something now that I more routinely discuss with my patients before we get them ready to transport home. So how do we approach transportation at Baylor Scott White Health? So we utilize, well, first of all, we use medical transport for all of our patients. And so vast majority is we're using BLS. We do utilize ACLS if we have, an infusion that is actively running, but otherwise we utilize BLS for all of our patients. It's a little bit market specific for us. So in Temple, we're fortunate enough to have our own BSW EMS to partner with, and they give us prioritization. So when we reach out and say that we have a patient that we need to transport, we get the next truck, assuming there's not an emergency that they have to respond to. In McKinney and College Station markets, we do have vendor partners for transportation. But as part of those contracts, we discuss upfront the expectations for turnaround times, and then when a patient has consented to hospital at home, we send our vendors a heads up, and that places us on will call for our transportation vendor. And so that way, when we do reach out to them and let them know, that we are ready to have transportation set up, it's already on their radar, and we're able to get pretty quick transportation. Some important discussions to have with your transportation partners, on the front end is just MOT awareness. A lot of these, transportation vendors are when they're transporting a patient away from the hospital, they are used to requiring an MOT, but that is not required in our patients because they are inpatients. Also, discussing the expectation for equipment transport is very important to have that discussion up front. So we send all of our patients who require oxygen, we send that oxygen equipment, the concentrator, the tanks, et cetera, with our transport team, with EMS. And that's something that, while of course the trucks are used to, having their own oxygen supply on hand, they're not necessarily used to bringing, someone else's concentrator and tanks and things with them. But because of the regulations surrounding oxygen transport, it's really important that at least in our model, it's really important that oxygen goes with medical transport. And so setting those expectations up front, making sure everybody understands the need and is agreeable to that, and building those workflows. And then finally, billing, we, in our program, in our model, EMS bills the program, not the patient directly. So we want to make sure that is known up front so that our patients aren't receiving, independent bills for that transportation. And as is important, anytime that there's a transition in care, we make sure that we have good handoffs taking place. And so our brick and mortar nurses are handing off to EMS, and then EMS to our program field nurse, who is waiting outside the patient's home for EMS to arrive, and then EMS will give them handoff at that point. And just a couple words on escalation transportation. So it's important to partner with your EMS Regional Advisory Council or RAC. Let them know who you are, what you do, the nuances of your program. As part of that, as part of those discussions early on, we educate the Regional Advisory Council that our patients will be identified by wristbands. So that way, they've seen our wristband, they know what it looks like. And if they're responding to a 911 call initiated by the patient, and they see that wristband on the patient, and they see all these medications in the home and all this, an IV pole and an IV in the patient's arm and all these things, they know what's going on. And they know that our preference is, if at all possible and if appropriate for the patient, to bring that patient back to our facility. There are some regional nuances with that, because in Temple is a little bit more or less in the middle of nowhere. So the 30-mile radius around Temple doesn't include really more than potentially just one additional hospital. And so it's much easier for us to ensure that, the patient's going to come back to us if we do have an escalation event. But for example, McKinney, the Dallas Northeast region, there's lots of hospitals in that 30-mile radius. And so again, it's just that upfront discussion with the regional advisory councils that, if it's clinically appropriate and we have the time, it's going to really be in that patient's best interest to bring them back to our facility. Of course, if it's truly emergent, they got to go to whatever is the nearest facility. We're going to do what's right for the patient. But that brings me kind of to the final point of, urgent versus truly emergent transportation back and an escalation. So if it's truly emergent, of course, 911 to the closest facility. But if we have the benefit of a little bit of time to plan, we're going to use our contracted vendor for transport if at all possible, because again, they know the nuances of our program. We're going to bring them back to our facility again, if at all possible. If they're not requiring immediate stabilization in the ED, we're going to transport them to a med-surg bed. And of course, making sure that all the transitions of care go smoothly with the doc to doc, nurse to nurse, all those things. So I'll pause there.
Thank you so much. All right, so I'm going to ask Hamali to make just brief comments on maybe some similarities or differences in transportation for KPNC.
Thank you, Linda. So we also started with mainly ambulance transportation to home, and we had to make adjustments. And as the program evolved, at this point, we are looking at about almost reaching almost 2/3 of our patients going from hospital or emergency room home via private transportation. So that's been a huge change for us. For escalations back to the hospital, it's always been ambulance. We also, when I talk about diagnostic, for certain diagnostics, we have to come to the hospital setting or outpatient. Those are also currently via BLS. There is an opportunity for us to look if there could be private transportation or other things like wheelchair van and stuff.
Great.
That's my
I'm
comment.
going to remind everyone in the audience, this is your moment to put in questions about transportation, because we're going to have Peters to say a couple words about Tampa General, and then it's the moment for questions on transportation.
Thanks, Linda. I think the way we look at transport is very similar to how Hamali does over at Kaiser. The majority of our patients go home with either private transport. I saw a question pop up about Uber Health. We use Lyft's health service for that private transport in most cases. And then, of course, we meet the patient where they're at. If they need a wheelchair transport, that will be the route. If they need BLS, that will then be the route for them. And so we do have patients go home via an ambulance service that we're contracted with, but we really try to leverage that relationship they have with the caregiver. It's a great opportunity as you're rolling the patient out to introduce yourself to the caregiver who may have not been in the hospital at the time, introduce them to the nurse, which usually happens at that point where we're loading the patient up. And then start the care at that point. And usually our hospital at home team is almost tailing the car on the way home, so they can immediately set up care once they're there.
Great. So I'm going to look at some of the questions here. So yeah, so we have, you answered the question about Uber Health. And then some people want more clarification on private transport. Well, what is your definition of that?
The private transport is like the family. So family taking the patient back home.
Great.
In their own car. Yeah. Sometimes we would also look at other transportation where it's a paid transport, but that's again private, not anything like BLS.
So I'm really curious about some of the timing of things. I think, Doug, you hit on some of this, that you can't wait super long because the ER is going to be upset, for example, and the patient will be upset. They said they're going to come, they want to go home, and if they have to wait whatever number of hours, that's a problem. So what do you hope for as time? What do you actually see in the transportation time from kind of ready to go to actually getting picked up?
Yeah, so for Temple, where we have our own BSW EMS, we let them know when we're ready. And if they have a truck that's already there at the hospital, then we get it, and it can be very quick. I would say in Temple, our turnaround time from the time that we request to the time the patient's out the door is usually under an hour. For our vendors, again, we have some contracted turnaround times. And in those cases, kind of to your point, Linda, it's, it's good to kind of balance asking before you necessarily are ready in that moment.
With some cancellation.
But not too soon, right?
Yeah.
Because you want to be ready for transport when they get there, but also if you're ready and then you ask, and they take, let's say, 90 to 120 minutes to get there, if we could have asked maybe 30 minutes before we were ready, then we can, better utilize that time, be more efficient.
Peter, you brought up something about, the nurse might be trailing the lift health coming home. So how do you ensure that so that patients, and same applies for Doug, right? The coming with an ambulance is someone waiting with the patient there until everything is set up. How do you do that logistically? How do you actually do that? The doctor writes an order, I want oxygen and a nurse visit. How do you make sure it happens? And I'm going to ask Peter that.
Yeah, it's always a challenge, and we'll get to talking about DME in the next section on how that is actually set up. I appreciate Doug mentioning, and that's very gracious of the EMT team to be able to take the concentrator out to the home, etc. But that's one of the things, right? Setting up, it's almost like on a discharge, right? You would set a patient home with a portable oxygen setup, right? So they'd be able to get from their hospital bed down to their private transport. The same thing happens with our program. We set them up with a portable oxygen supply. So they'll be able to have oxygen on the way home. And then, of course, they have sort of a clock ticking because that tank is only going to last a certain amount of time for our team to be able to get out to the home. So looking at traffic patterns and the length of the oxygen that they're on and how much flow they're on, all of that goes into the calculation on making sure they have the appropriate oxygen supply from discharge, not discharge, transfer to the hospital at home program.
Well, I think we're going to have to switch topics here to make sure we stay on time. You still can put questions in about transportation. We will still look at them and get to them at the end if we have time. But we are going to switch to logistics, DME example, and I'm going to turn it over to Dr. Chang.
Thanks again, Linda. So, the way we approach logistics is probably the biggest challenge with a hospital home program scaling. And as we start to look at DME specifically, when our program was just starting and we were small, we said we would internally source all of the DME. So what type of DME? These would be, walkers, nebulizers, bedside commodes, and wheelchairs at times. Of course, we weren't going to source our own hospital beds for obvious reasons, but the DME that we could be able to transport to the house, we were going to be able to take care of. And so in that first part of our evolution, that was number one. And then figuring out how we would actually deliver that to the house. Different programs use couriers. We actually had the clinical team deliver. And so the hospital at home program internalizes all of the costs, right? Because the patient's still in the inpatient episode and we can't bill for any DME officially until the patient's discharged. On top of that, at the time, we did not have a DME company that we were partnered with or that we had. So in that sense, we had to figure out how are we going to do this? And having a nurse being able to log a, 30, 40 pound concentrator upstairs, et cetera. We've worked through kind of all of those challenges and making sure that the nursing team at least knows the expectation, et cetera, on actually setting up that patient with the home oxygen when they get out to the home. Other DME nebulizers, bedside commodes weren't too bad. A bedside commode's just a little clunky to carry around, but other than that, it's not too heavy. Looking at our second phase of figuring out, how do we progress? This would be to still insource the DME, but we would have a partner with a DME closet. So we weren't sourcing it through our own supply and distribution. That's another way you can look at it. And then the delivery method is very similar. So in this case, again, no billing occurs because of the fact that, the patient's still in the inpatient episode. And then, of course, moving to version 3, we joint ventured a DME company. And so now we had a close partner, right? In versions 1 and 2, even if your DME partner did source that, you're paying them for them to, basically put it in a DME closet. They could bill on it when they get it, but you're doing all the work to deliver it. So it's kind of like what's in it for the health system if that reimbursement's going to a separate DME company. But in the case of option 3, which is sort of a hybrid approach, you're actually sourcing your DME from a vendor who probably has better contracts than you do on the equipment. They can either keep it in a DME closet, as we mentioned in the previous example, or even potentially deliver some of that equipment for you. In that case, either our nursing team or that clinical team or by the vendor could deliver that DME out to the patient. And then in this case, since there is a relationship between our hospital system and our joint venture DME, we could actually create sort of like a voucher system where we'll track that DME, what it was, that it was set up, delivered in the patient's home, and then upon discharge, our DME company could go ahead and submit the bill for that DME. So it's kind of, the best case scenario, best of both worlds in that hybrid function, because you can bill upon discharge. And then the last flavor is really looking at an outsourced model completely. So saying, I don't want to do any DME. My vendor is going to supply my DME. They're going to deliver it and set everything up. We were a little skeptical about going this route for obvious reasons. When you're looking at something that's timed like oxygen, we didn't want to have any service level agreements get breached and a patient maybe didn't get what they needed in time. Our nurse is there, the patient's there, but the oxygen concentrator is not, and the tank's running out. What are we going to do? That also requires that DME vendor, in the case of oxygen, to come set that patient up at the hospital, which again, sort of like what is the end goal of it. And really that hybrid model we've seen very successful as we start looking at, growing our joint venture DME business together and making sure that our patients are getting, excellent service. So this is just one example of kind of the logistics as we talk about DME specifically.
Great, thank you so much. So now I'm going to ask Doug and Hamali to comment about some similarities or differences with regard to DME logistics. So maybe Doug?
Yeah, so we, I think we follow maybe somewhat of that hybrid model where we do have a DME closet with some of our equipment on hand, like oxygen concentrators, walkers, bedside commodes, and then some of the other DME that we source from vendors who will, deliver to the patient. Again, as I mentioned in the transportation section, our oxygen is transported through EMS. Sometimes they'll take our walker and our bedside commode as well. Otherwise, our clinical team will deliver to the patient. We own the walkers, we clean and store them. The bedside commodes we gift to the patient. For obvious reasons, we don't really want those back.
Hamali?
I will give a couple of examples. We do also have the storage and we keep the walkers in the emergency room and hospital. But like for CAT pumps, so our DME supplier had a hard time tracking out the CAT pump, and they removed them from our capabilities. So at this point, we're not able to use CAT pumps, so we cannot have patients with certain IV antibiotics like Unison or high volume IV fluids. The other example I would like to give is that we have 2 DME vendors. One of the supplier is very good with turnaround time, like of 4 hours, and they're very reliable. So we use them as much as possible but it's county specific. And the other DME supplier who is not that reliable is sometimes not able to meet our service level agreements. So we have now, we keep the concentrators, and then our home health nurses would provide the concentrators, and then the DME will supply the backup tanks within a certain period of time. So we had to do a lot of process improvement and workflow processes for the oxygen delivery when patients are leaving from the ED or the hospital.
Yeah, I'm hearing this theme of oxygen because it's the tanks and the concentrator, and you can't be without as a theme of challenge for all of you.
Linda, and
Um,
I will say
Go
I'm
ahead.
a little at an advantage because prior to going to medical school, I ran DME for about 2 years. So as we set
Excellent.
up our program, it was very convenient because I knew exactly how to do it. And to Doug's point, since we did mention that we weren't billing, the patient just keeps the nebulizer, walker, bedside commode, and we just eat the costs.
You mentioned something earlier, Peter, about figuring out how much time someone has with the transport and maybe the traffic and who does that? Like the doctor writes 2 liters by nasal cannula, right? Then are you expecting them to do that calculation, or how do you figure that out so that the patient gets what's needed?
Yeah, so at Tampa General, we created a position called the care manager position. And it is an RN, but it's not the RN that's taking care of the patient. And so this care manager, we kind of call our care managers kind of the guiding light of the program. They're folks that help screen with admissions. They will go ahead and do some basic setups of different types of equipment, and really help coordinate the logistics. Right, this is something that we have partnered with a technology vendor that we're looking to help automate. And I think that's really the biggest challenge. If you have antibiotics due and labs to pick up and you're running those back at your health system, how do you time all of that and then coordinate with your nursing assignments? It's a straight up logistics problem like UPS or FedEx and getting something from point A to point B and looking at where your transportation assets are. So right now we battle it with people, but we hope very soon to enable technology to do some of this logistics and planning for us.
So that the provider writes the order and that nurse coordinator is getting the order, and then he or she is mapping that out as how to make it work. Got it. We have a question in the chat on who trains and educates patients on DME, if it's being delivered, let's say, by the paramedics in the ambulance, with the patient. Is that person expected to do that training, or how does that work? Maybe that's a question for Doug.
So it's our field nurses who educate and train the patients on DME. So even though EMS is helping to transport that equipment in most cases, again, the field nurse is there waiting for EMS to pull up outside the patient's home for that start of care visit. And so they'll go ahead and during that start of care visit, make sure that the patient is trained on DME use.
Linda, I think you're on mute.
Thank you. Any difference for Hamali and Peter on how the training happens in your programs?
I think it's a combination of the DME supplier, they go home, and also the home health nurse that's going to be in the home setting.
Yeah.
Yeah, we use our field nurses too, are the main set of team members that do the orientation training for the patient.
All right. I think we were going to move on to the third topic, and then we can circle back with any leftover questions afterwards. So I'm going to turn this to Hamali to talk about diagnostics.
Yeah, so I'm going to break this up into 3. I'm going to talk about labs. I'm going to talk about some of the imaging studies and then EKG. So we can go to the next slide. So the lab is mapped. Because we have 8 medical centers in different regions, the labs are mapped from certain medical center to a certain lab. So we have currently 2 or 3 labs that process this. So it's drawn in the home by a phlebotomist, like a vendor, or the home health nurse if they're present. In fact, if a home health nurse is present and they draw a lab, they will even drop it off if it's on their way. It will be dropped off to the closest KP inpatient lab facility. The turnaround time for STAT, they're all processed STAT, and the turnaround time is 3 to 4 hours. At this point, we are waiting for a CLIA license from home health vendors, so we don't have the point of care testing. We also partner with Medically Home for our advanced care at home program, and we use their Stacia platform. So I think the challenges are the courier cost and how to batch it and drop it off. All local inpatient labs require training on the ACA program. We call our advanced care at home ACA program. And some of the labs cannot be done in the home, like lactic acid. So either we just don't draw it or we don't have the patient that would meet them. So at this point, chest x-rays, abdominal ultrasound, and vascular ultrasound are the three things available in the home setting. For all other x-rays and imaging like CT, MR, echo, the patients have to go back to the medical center. Now, the studies can be performed at home within 2 to 6 hours. The preliminary read is from the technician, and we get the read from the radiologist once it's uploaded, which may take a while, but it can be within a 4 to 6 hours on the weekdays. Weekend, it takes a longer time. There are also things like taking a picture, sent to the doctor, physician to read it. At least they see it. If you're doing an X-ray looking at pneumonia, CHF. Currently, we lack the interface, the software interface, where it goes directly from the vendor to electronic medical records in KP. So, of course, it's very convenient for the patient to do it home. It prevents them to go into the hospital setting. But we have to do these steps very accurately, because even if one step is done incorrectly, there are delays to upload the imaging into the electronic medical record and for the radiologist to read. Other than these studies, as I said, they have to go back. If it's urgently needed, then they go to ED. If it's a non-urgent, then they go to outpatient radiology. Again, some of this is a very complicated manual process, so we are looking into how can we make it more efficient. And the next slide will talk about EKG, which is another clunky process. The EKG can be done in the home setting. So here also the photo of the EKG is taken in real time, and that's generally given to the physician who is taking care of the patient to read it. Now, how to upload this in the EMR, actually the cardiologist has to create an encounter, and they cannot post the picture. They only post the reading of the picture into the EMR. Echoes must be done at the medical center. So even for the EKGs, currently we don't have an interface for uploading it directly from the vendor into the KP medical record. And it's a burdensome workflow. Our cardiology colleagues definitely don't favor it. The turnaround time is within 2 to 3 hours, but definitely convenient for patients when they're at home. So, Linda, I can give it back to you for questions and panel discussion.
Perfect. We have a fair amount of questions coming in at this point. So I will do briefly. Doug and Peter, are there comments you wanted to make about how things might be different or the same at your programs with regard to these diagnostics?
Yeah. So yeah, just a few comments. As far as point of care labs right now, we're only doing glucose, but looking to, potentially expand that in the future. For imaging, we're partnering with a vendor for in-home imaging like X-ray, ultrasound, and actually echocardiogram. EKG is done in the home by our field nurses. And I think just a quick word on just labs in general in the home. I mean, we found that certain DRGs that we're treating, for example, specifically AKI and CHF, it's helpful to have those labs drawn and resulted before that day's virtual visit, because a lot of those treatment decisions are lab result dependent. And so if in the case of our program, I mean, we utilize all RNs into the home, and they're the ones drawing the labs. And so if we're waiting until that rounding call visit to draw the labs, then we may not have those results back until later in the day, and then we don't know what to do with the Lasix until then. We got to send another nurse back out to get the Lasix. So in these situations, we're often utilizing our nighttime nurse to go early in the morning to the patient's house, draw the lab. Still an additional visit, but it's an additional visit at a time that's maybe less hectic than in the middle of the day, trying to send a nurse back out to the home to give that Lasix when we're in the middle of admitting and discharging, et cetera.
Yeah, I would say we're almost identical to the way Doug's doing it. So interesting how the programs kind of mimic each other, even without information exchange, but very similar. We run all of our labs back here at the main hospital. We have some freestanding EDs. So I will say, I know we're not supposed to talk about specific vendors, but in the case of Epic, that's our EMR. And so with the implementation of Beaker, that really opened things up for us to be able to drop labs at our freestanding EDs. And has allowed us to kind of extend a little bit further and using those freestanding EDs as launch points for hospital at home. I would also say from an imaging perspective, we did partner with a third party vendor to do ultrasound plain films and echoes in the future, because we're still trying to Hamali's point, figure out how those echoes are coming back to be read by our cardiologist. And with all the information living inside of our EMR, we didn't want this to be read by an external cardiologist and just bringing a read. Just trying to keep the continuity of care. Same thing for the reads on our films that are done by our third party vendor. EKGs our field nurses do.
Yeah, it's tricky because those under the waiver, at least, it's different, of course, if you have contracts, the staff has to be credentialed who are reading those things, right? So it gets tricky sometimes.
Yeah,
All right.
Linda, sorry, Linda, I will also say, I know we kind of combined the first one and the third one, but for imaging studies done back at the hospital, so if somebody needs MR or CT, then we would follow kind of the same transport policies that we had in the first session we talked about, to get the patient back to the hospital, get the study done, or in one of our ambulatory centers. That's also an option too from an imaging perspective.
All right, we have a lot of questions, so go ahead, Molly.
For us, the vendor does the EKG, so not the home health nurse. And then here there was a question where they asked if the chest X-ray was done in the home, and yes. Thank you.
So we have a couple questions about, so besides point of care labs and mobile x-rays, is anyone looking at newer options like portable lab units or portable centrifuges to spin down blood so it lasts longer? And then they said, or portable advanced imaging like CT or MRI. So is anyone looking at any of those in their program?
I would say at this point, it's sort of cost prohibitive from a portable MR, like in a truck, or a CT in a truck kind of thing. I think it's definitely something we can explore if the demand is great enough, but usually from an advanced imaging perspective, we try to make sure the patient has some of those things completed before they leave the hospital, whether it be from the ED, and really try to, I think one use case as it pertains to these things is really cause the clinical team, the providers, to look at how we order tests differently, especially as it pertains to lab utilization is much less than it is here inside of the walls of the hospital. And the last thing I'll say is too, I am point of care ultrasound trained, so that definitely does help. And we did buy a portable ultrasound iPad device that I've used quite a few times to do fluid assessments and those sorts of basic studies. That's extremely helpful prior to creating a contract with an imaging vendor.
We have another interesting question about, is anyone using any program software apps to teach both transportation and DME? I think that's to the patient, I believe. So what are you using to teach, I guess, about, what to expect? I hope I'm reading that question right.
We're developing some content that can be viewed through the entertainment system within a patient's room for the patients that are coming down from an inpatient perspective, to give not only like an introduction overview to the program, and that content's in development right now, and we hope to launch it so that the patient can kind of get oriented with a video, even potentially before an enrollment team comes to see the patient.
There are a fair amount of questions about how is everyone managing the logistics of like the order to fulfillment? I think we hit on a little bit of that earlier. And I know we're trying to stay away from like advocating for certain companies we might use and all that, but can you maybe describe a little bit about, is it an Excel worksheet? Is it like a program, a software program? How are you managing all that for order to fulfillment? And then there's another question that's similar about how are you managing tracking oxygen concentrators or IV pumps to make sure you're getting them all back? Both of those, I think, have similar responses.
I think I can just talk about like tracking the patients and where they are in the journey with multiple admissions going on. So our teams with the home health have the Teams chat going. So it's a very active Teams chat, and it's constantly um, um, going on with the with the virtual nursing as well as the physicians and um, local medical center to let them know where they're in the journey. As far as what was the other question, Linda? Sorry.
How are you just, organizing the patient's day about all the orders that are coming in so you get the right thing to the right time to the patient's home, order fulfillment?
Yeah. It's a little bit clunky, but continuously like updating, especially when we talked about how the transportation can be delayed versus not. When is the team going to be reaching at the patient's home when they reach the home? So that's a lot of communication that goes on. We also have hired the medical center liaison. We have a non-clinical person that's in charge of like 2 medical centers. They actually go and visit one medical center, 4 medical centers per person, and they go in person once a day, and they're constantly connecting with the patient care coordinators in the hospital and teaching them on how to keep the patient's communication and education on, and how do you then also keep your communication channel open with the acquisition team.
In regards to getting equipment back when it's time for discharge, if it's equipment that belongs to us, then our nurses will bring that back after the discharge. If it is vendor equipment, then we send. I mentioned kind of a heads up email on admission. We send an email to the vendors notifying that the patient's being discharged as well, and that's kind of their notification that they need to go ahead and coordinate getting their equipment back from the patient's home.
Yeah, we basically created a QR code and a SharePoint app that we created inside of our own Microsoft environment that basically is like a DME tracker or equipment tracker. So we can keep an eye on where our LTE iPads go, where our concentrators are at, where IV pumps are at, IV poles, etc. It's not perfect, but it's sort of at least is not a spreadsheet, and we can kind of keep track on it. And it's easy for the nurses just to scan the QR code and answer a couple of questions on a mobile app. I would say we are in current development with a third-party vendor to create an end-to-end solution, everything from enrollment all the way through post-discharge follow-up. And everything in between as it pertains to logistics. It's a pretty big one to crack, but we're looking to do it with technology.
All right. Well, thank you everyone for joining us today. We're going to wrap up now. So Gabby, if you move to the next slide. I think we did the Q. Yes, here we are. So a reminder, we do have the users group has a caregiver experience study going on. Please scan the QR code or email if you have a caregiver who might be interested in being part of this research. So we are webinar number 30, and it will be on the website in a few days, let's say, and you're welcome to watch this webinar again as you are able to watch all 29 other ones. It's a nice library of the webinars and other technical assistance that's on that website. So here was a free, here's our website and the TA Center, and the featured resource we want to say today is structuring hospital home programs as an ambulatory model. So that was just in case the waiver wasn't extended, some resources there for that, or the webinar that we had on that last month, I believe. Fingers crossed. We go through March 31st right now, but hopefully it will be extended. So thank you again to our sponsors, the John A. Hartford Foundation and the American Academy of Home Care Medicine. And thank you all for joining us today.